Dr. Coll. I'm an orthopaedic surgeon based in Cairns in far north Queensland. And tonight I'm very pleased to educate everyone about vertigo and dizziness and what we can do from a physiotherapy perspective to help these patients. Thank you very much. Come on.
So, thank you for having me here for this talk. So my name is Maigi, I'm vestibular physio at Wellness and Embodied Cairns, and all my main caseload is dizziness, vertigo, balance problems, and concussion clients. So I'm going to talk about common causes of dizziness and vertigo, and as a physio, what we can do to help them. I have done a lot of courses throughout the years about dizziness and vertigo management in Australia and with US faculty as well. So I'm really passionate about this topic. So first of all, talking about dizziness and vertigo. A lot of times people use a lot of different terms when they are not feeling well. So when we talk about vertigo, we actually talk about room spinning or self-spinning sensation. And sometimes I hear so many different ways how people describe they're wobbly or off balance or not feeling well in their head. So there's so many different terms. But for me, it's really important to identify is that actually that room spinning vertigo or it's something else. Do they feel off balance? Do they feel when they move that their vision is bouncing? So because all of this is helping me to identify what's going on with them. So our balance is a combination of the vestibular system. So vestibular system is a little system in our inner ear. I took my little inner ear, so vestibular system and hearing system as well. And vision, and then perception or whatever is like touching the floor. All the brain has to interpret all of them and put it together for balance. When people have problems with the vestibular system, they have increased risk of falls, especially when we talk about elderly. When younger people would perceive that vertigo more like a spinning, elderly people would perceive that more like off balance, or they have more frequent falls instead of actually feeling that spinning. And that's again with aging, with all the senses decreasing, and because of that. So another person who I would see is the people who fall a lot. And a lot of things that my clients are telling me is that the dizziness really impacts their mobility. They are not going out anymore because they don't feel safe. They're afraid of falls, especially when they have osteoporosis as well, or bone density problems. It affects your driving because when you're feeling dizzy and you have to turn your head to look around, you're not feeling safe there. It affects your work capacity. There's conditions that actually will give you a bit brain fog as well. So cognition is affected as well. Mental health. When you're feeling dizzy, it's such a condition that you can't see. When someone breaks their foot, you have the moonboot on, everyone can see, can be compassionate, but with dizziness, can't see it, so it has so much more impact on mental health as well. And then social participation. There are conditions that give people really overwhelmed, dizzy feeling in a bright places, like going to the supermarket or going out to have a dinner. So that might pull them back from doing those activities. And as you can see, confidence and independence. When you're not feeling well, it's really going to affect your independence. So with vestibular system, so it's really tiny in inner ear. We have one on each side, and I have it here. So it has semicircular canals, 3 on each side. So semicircular canals are helping to detect rotational movement of the head. Then we have a utricle and a sacral. So utricle is more sensing linear acceleration. So basically when you're riding in a train and the train starts going, you will sense that. And sacral is more the vertical movements, so riding in an elevator. And then vestibular system itself is responsible to keep the vision stable when we move our head. So that's the VOR, vestibular ocular reflex. So as I mentioned, it helps to detect head movements and maintain the balance, stabilize vision during the movements, and maintain like spatial orientation as well. So when we talk about vestibular syndrome, we have different, we have acute vestibular syndrome. So that is when they have this acute persistent vertigo lasting for days to like even weeks. So that would be the acute syndrome. Then another one is episodic. So that's the recurrence. They might have like those dizzy days for like for a day, and then nothing then comes again. So that would be more episodic. And then we can talk also about the chronic dizziness, that these are the people who come in and they have had dizziness for 5, 10, 20, 30 years. Episodic dizziness and the acute one as well, like they can actually go into the chronic if it's not managed well. So when we have someone coming in, so me as a physio, what I would do is called titrate. So I'm always asking about the timing of the symptoms. So is that, can I see, is there that pattern that is episodic, or it's just started and is going? Then it's triggers. Is there anything that triggers the dizziness or vertigo? Is that positional triggers? Is that certain activities they do? Is there any like hormonal things that they can put it together with? Like just to see is there actually triggers, or it comes on with no reason. And then the ATE means untargeted exam. So as a physio, we do targeted exam. As you can see on my slideshow, I'm using Vesticam infrared goggles. So this is what I use in my everyday work. So because a lot of times, like assessing dizzy people is, we need to use these ones to see what their eyes are doing in complete darkness when they cannot fixate their gaze. If you don't have these ones, it would be like being a cardiologist without having the stethoscope. So it's really important to like actually to have comprehensive assessment. When we have someone coming in acutely, we do what's called Hinge Plus test. So that is like the head impulse test, looking to nystagmus, so eye movement, and test of skill. So that's like covering their eyes. And that's just to see, because what we're doing in acute case is we're trying to identify, is this stroke or is actually the inner ear system? Mm-hmm. And that's going to be more accurate initially than actually having an MRI straight away. Mm-hmm. So, and the plus means they're plus hearing. If there's hearing loss, then we would be more worried. So today I'm just talking about 5 different common causes. So the first one would be the vestibular neuritis that probably people have heard, and this can cause people to have unilateral vestibular hypofunction. So what it means is just one side of the vestibular system is not working as well as the other side. The other one I'm talking about is benign paroxysmal positional vertigo, BPPV. So that is the really common that people will hear about crystals in the inner ear. So that's usually the one that people refer to. Then vestibular migraines, persistent postural perceptual dizziness, short 3PD, and just quick chat about concussion as well, but Eliza already had a really thorough chat about concussion a few months ago. So these are the conditions that can give people dizziness and vertigo. There's a lot of other conditions as well, like probably people have heard about Meniere's disease. There's more less common diseases as well that I have brought some of them out there. And then we have the conditions that actually are more central, so brain driven, like stroke or MS, that can give people dizziness as well. And then panic attack stress, anxiety is like another one that we see as well. So the first one is the acute vestibular neuritis. So this is when the vestibular condition that is caused by the inflammation of the vestibular branch of the 8th cranial nerve. So it can affect like superior or inferior nerve, but it's more commonly superior nerve. So basically what happens with people is they get this severe vertigo that lasts at least day to even 3 days. So they usually get really sick, they vomit, they usually end up in BPPD because they're worried that they're gonna have a stroke. So it's really severe vertigo. When you do the testing, for us it's really, usually with this condition it's really easy to identify if it's peripheral, because they get this nystagmus that is direction fixed, and then when we do the head impulse test, we can see the gaze lag to catch up the case there. And yeah, but these people usually get really sick, so usually they end up in AV before they actually come to see us. So, and the vestibular neuritis can leave people with unilateral vestibular hypofunction. So after they have, usually the neuritis, a few days really sick, they're more like bedbound, then we want to get them moving as quickly as we can. And then as I mentioned, the vestibular system is responsible for the gaze stability. So these people will have trouble with gaze stability. So every time when they turn their head, they will have a gaze lag, and they will have a struggle with this, and they will feel dizzy with the head turns. So they also will experience this brain fog, especially at the end of the day, because if you can imagine, if you have trouble with catching up with your brain, with the gaze, it's just gonna overwhelm your brain as well. And as mentioned, the vestibular system is contributing to high-level cognitive processes as well, like attention, spatial perception. So a lot of times they, at the end of the day, or when they have to get back to work, they feel that they get tired more quickly. So what we do as a physio for these people, we start to work on a gaze stability training. So this is really specific exercises that we ask them to look the target and actually move the head away. So we're going to do these quick head flicks, depending how they can tolerate it. And then we will progress it to different with a movement or with more visual background as well. So, and then we're really going to work on the balance as well. So balance training is another a really important part to work with them, because initially they're going to be really off balance, especially with eyes closed. So because then they have lost one side of the vestibular system, and when we take vision off as well, they're really going to be off balance. So this next one, that's the BPPV. BPPV is very common. So this is the people who might get brief spinning episode when they change position. If the previous one was really initially starts acute spinning ongoing, and then as they get better, they get a little gaze lag. BPPV is only positional because it's really mechanical. Every time when the otoconia, so basically what happens, otoconia goes into one of the, or sometimes can be multi-canal as well, but goes into the canals, and then when we move our head, the crystals otoconia moves in there, and then that's the time when people get dizziness. So it's always under 1 minute, really short lasting, but again, it can make people sick, depends on the person as well. Sometimes they just, again, can just perceive it as a dizziness, sometimes it's people full on spinning. And it always comes on with a position change. So, as I mentioned, this is the one that really commonly is referred as crystals in the inner ear. And this is more so when you have had it once, there's a chance that it might come back. And then higher recurrence is with head injury, because with a head injury, because makes sense because it's just the impact. And then with people with low vitamin D, being female, osteoporosis, and it's also associated with migraines, higher reoccurrence. So as I mentioned, BPPV can happen. We have 3 canals on one side, so it can happen with whichever out of those 6 canals. And how we know which one it is, we're actually doing the testing. So we do the Dix-Hallpike testing. That's the one that we're going to put their head over the pillow or over the edge of the bed, and basically we're going to put the canal on a plane of the gravity and then test it. So the nystagmus is the eye movement, will show us which canal it is. So that's why we need the goggles, because sometimes it's really quick or really small, so we want to make sure we don't miss it. So with PPPV, there's different variants. One is when the otoconia is free flowing in a canal. So when we put them in a position, you get the nystagmus, it gets quicker, slows down, and then it stops. And the other one is when the otoconia is stuck on a cupola. So that's more when we put them in a position, we get the nystagmus, but it's ongoing. So again, when we do the testing, maneuvers is the treatment is maneuvers for them. And maneuver, it really depends what we can see in a testing. So maneuvers are really different. Most commonly, it is the posterior semicircular canal. So that's the most common one that would happen, and that's the one that most people know that there's a maneuver for that. So that's the usual people know. And there's some atypical variants as well with new research that is coming out, which is less commonly seen. Treatment-wise, as I mentioned, we are testing the canals, and then what we can see there, depending on that, we're going to go through the maneuvers. There's different maneuvers for each canal, and if the otoconia is free flowing or if it's stuck there. PPP is really common as well, after some surgeries when people have been on a bed rest, especially elderly. If they have had a bed rest longer and then more sedentary, then it can happen with them as well. So I have a recording next. So this is one of my lovely client consented to show this. So this is when I put the person down into the Dix-Hallpike testing, and then there's the nystagmus coming. So this is me just having a still chat with her. So this is left, that's right side. So this is me putting her down in position, and then you can see it. So she has right side posterior canal PPPV. You can see how the eye starts a bit upwards and a little bit turns to the right. So that's what I said when I said it's going to go quicker and then it's going to slow down. So this is where my client was feeling really symptomatic as well, and then it slows down. So this is how we identify which canal it is, because if it's giving me this pattern, as it was at the moment, that's the posterior canal. But if it would be, when we do another test and it gives me horizontal canal, it will be more like the horizontal canal, if it gives horizontal nystagmus. So yeah, so we just do the testing, and according to what we can see, we go into the treatment. Next one that is really common as well is vestibular migraines. So the diagnostic criteria, according to Barani Society, is to have at least 5 episodes with vestibular symptoms of moderate or severe intensity, and they're lasting 5 to 72 hours. So the other one that needs to be filled as well is current or previous migraine history, with or without aura, according to International Classification of Headache Disorders. And then 1 or more migraine features with at least 50% of vestibular episodes. It can be the headache, or it can be the photophobia and phonophobia, or visual auras as well. So vestibular migraines are really common, really prevalent as well for me, working with the Dizziness and Vertigo patients. These people usually get this episodic dizziness, and then these vestibular migraines can come only as a dizzy spell, maybe with a photophone, a little bit photophobia or phonophobia. They don't have to have that headache at the same time, but we want to. So they sometimes they come in and they don't have the headache during the same spell, but they have had some spells in the past that they have had with the headaches, or they have the migraine history. So common symptoms would be those that vertigo, they get really motion sensitivity. A lot of times when we talk, they are these the people who can't drive up to Grander Range, or they have been always motion sick since they were kids. They get visual sensitivity as well, going to the supermarkets, the lights are really they can't tolerate that. Light noise sensitivity, brain fog, especially after the vestibular migraine attack, and imbalance, nausea. And as mentioned, these spells can be without the headache as well. So can be just those vertigo spells. Management. So it would be similar like to regular migraine management, a lot of education about it, especially sometimes they get this aura before as well, so they are really fearful. So then finding the triggers. So as we know with migraine, it is more if they do, for example, if their triggers are like emotional stress, like hormones and the sleep, we're always educating them, like if you know that you have this pre-week meeting coming ahead, make sure you have a good night's sleep before. You don't want to have all those triggers piled up on the same time period, because that's going to tip you over the edge and you're going to end up with a spell. Another one that's really common is like neck pain as well. So that's what we do. We do the mobilizations on the upper neck or upper back as well, depends where the tightness is, to help them to keep the spells under control. And as we know, some food triggers, alcohol, heat, and weather changes as well can trigger them. The other thing that we talk with them is definitely sleep hygiene, because if you're not having a good night's sleep, your symptoms will be more prevalent. Exercise point of view, we are working on a balance strengthening aerobic training. Habituation is basically exposing them to these like activities or environments that are making them feel more symptomatic. Relaxation techniques, breath work, hands-on treatment for the neck and upper back. And then we will always talk about like workstation modifications if they're working behind the office desk, and that gives them a lot of postural strain. And then if with the physiotherapy we can't get it under control, then we would recommend to see the GP to have some medications as well to help them with the management. And as mentioned, these people, like 30 to 70%, have motion sickness as well, and visual vertigo is really common with them. 3PD, this is really interesting condition as well. So this is this persistent dizziness. It can wax and wane throughout the day, throughout the days. You might have like a days that they're feeling pretty good, the other days that it's really gets worse. And there might not be any like triggers they can associate. With vestibular migraines, when they have had a lot of vestibular migraine attacks, it can actually progress to this 3PD. So basically, what 3PD is when they have had dizziness or unsteadiness or that non-spinning vertigo at least 3 months, and then usually symptoms worse when they're upright and walking. It's usually worse with passive or active motion. So it can be like when they bend down, when they come up.
All good?
Yep. All good. So yeah, so it is worse with active or passive motion. So as I mentioned, 3PD can be worse with like active and passive motion. So some people get self-motion sensitivity when they bend down, come up, they get a bit dizzy, or like more with exposure to moving visual stimuli or like really complex like visual environments. Like as I mentioned, going to the supermarkets, Stockland Center, no one likes them. Going to like eat out in a restaurant. And usually this disorder starts like some acute event, like a health event, can be psychological distress, some vertigo event, like as I mentioned, vestibular migraine events, or when they have had a BPPV, or like other medical or neurological illness, and then it can slowly progress into that, or and these are the people that usually have tried like different places to find like help, because the dizziness is really persistent, like difficult to find the triggers. And as I mentioned, a lot of times there's like if they can't identify like what triggers, because it just accumulates over time. Management. As I mentioned about vestibular migraine management and 3PD management, it's really personal and tailored. So this, like what I'm telling here, it's more like universal, like what we would use, but it depends on person. Like if you don't have, like if when we work with you and your balance is okay, you don't need balance exercises. So we really like do the assessment, what we can find, and we treat accordingly. So 3PD management, a lot of it is education, for them to be aware of the condition, just to explain like if everything else has been looked into, and just to help to calm like the nervous system down there as well. Habituation exercises are the exercises mentioned, like if they are feeling really overwhelmed, dizzy in these busy environments, we start with some video recordings to help them to be more comfortable with them, and then with like exposure therapy there a little bit, and then going into more these environments. And the same for self-motion. If self-motion is giving them more dizziness, then we're going to give them habituation for that. Balance training, as mentioned, as needed. Management plan. That is when they're getting when the symptoms are getting really bad, they will be aware what they can do to make them feel better. So they feel that they get the control over their symptoms. Regaining independence and confidence with different exercises, because a lot of them have, as I mentioned, the same. They're not going out because they're feeling dizzy. They have like drawn back from the social events because they don't want to go to the like cafe or anywhere because they feel that it's going to be too overwhelming for them. Breathing exercises, same with the grounding meditation, all that will be really helpful. But again, it's really it depends on the person who will find it helpful and who will not. So we will really, like with the assessment when we trial the treatment, we will see like who will get better with what. Group classes, strengthening aerobic training, and then psychologist will be a really important part of helping them out as well. And again, medications is like another one when, like with the physio, we can't get it under control and it affects their life so much. And there's a little drawing about how a lot of times in the vestibular world, there is not only one condition. A lot of times those complex clients will have two or more conditions. And two of them that are really commonly coexisting is vestibular migraines and PPPD. So as I mentioned, like a lot of times in the vestibular world there can be several conditions coexisting, and two of them really commonly is vestibular migraine with PPPD, just because, as I mentioned, when people get vestibular migraine episodes, it just can trigger the PPPD as well. And then this is just like a nice drawing, like how the people would feel. Like they have this baseline dizziness that's PPPD, and then with attack they might get the vertigo attack, and then that might be lasting like a day or two, or sometimes just hours, and then like they go back to the baseline like PPPD. But as usually when they get those attacks, that can bring the baseline a bit up as well, the symptoms. So again, like really important to manage that. So and then as mentioned, the one condition as well that can give people dizziness or can give PPPV because of the impact is concussion. So our clinic is concussion clinic as well. So concussion can happen when you have an impact in the head, but also impact onto your body. So it doesn't need to actually, you don't have to actually hit your head, or you don't have to lose your consciousness to have a concussion. And when symptoms are prolonged, then people can end up with post-concussion syndrome. And the concussion gives people really different symptoms, starting from sleep disturbances like brain fog, memory problems, neck pain, headaches, irritability, the mood changes. It's just a lot of different symptoms, and again, depends on the person, like symptoms can really vary. From a physio point of view, so acute concussion management, Eliza already talked about this, but basically if I go quickly through, it depends on the time when we see them, SCAT 6 or SCOT 6. And then we're going to do education, reassurance. We will book into Buffalo concussion test. That's the treadmill test to see the aerobic, like how they can tolerate, how the symptoms will respond when we get the heart rate up higher. And then according to that, they either pass that or we give them exercise to work on a certain heart rate level. And then we will check the neck and the vestibular system as well if they get dizziness. From concussion point of view, like when people have had it, PPPV is really, like post-traumatic PPPV is really common that they can get. Or like sometimes can have like some unit vestibular hypofunction or like different conditions. Again, testing will like show us. And when the concussion symptoms don't resolve straight away, it's going to go into post-concussion syndrome. That management, we still do the same like SCOT 6. So we're going to do the Buffalo test, the neck assessment, and then vestibular assessment. Before we get them back to training, we have also the when they're symptom-free, we do the Black Box test to see are they ready to return to like training, if these are the athletes. If just everyday people, then we do the Buffalo test instead. I want to see how they can tolerate aerobic training and how their heart rate is reacting, but they don't have to do the Black Box. And again, the same still like education and reassurance. And then, depending on the symptoms, we treat what is causing the symptoms. And why to see a vestibular physio? As I mentioned, we will do comprehensive assessment, and that will lead to correct diagnosis. With vestibular migraines, as they can give people dizzy spells, or as mentioned, some people can get that self-motion sensitivity with like PPPD. So that can be, that self-motion sensitivity can sometimes be misunderstood as like BPPV. So when we do the assessment, we will see what it actually is to make sure we treat the correct thing. Vestibular neuritis or versus stroke, again, like assessment, like we will identify this. Just to make sure the person gets correct treatment. And a lot of like when people have had like acute vestibular neuritis, the earlier treatment, better outcomes. Correct equipment for the assessment and treatment, as I showed like on the pictures as well. We used infrared goggles to see actually what the eye is doing in vision denied positions. So correct treatment, PPPV, for example, as mentioned, 6 canals, 3 on one side. We need to test and treat the correct canal. Again, trained vestibular physio would be able to identify the canals and do the correct treatment. Same as I mentioned, there might be multiple conditions like vestibular migraine and PPPD together, so we actually need to treat both of them. And then this is like also helping to reduce the risk of falls and then gain back your independence and achieve the goals. Thank you.
Wow, well done. Thank you. You got questions first?
I have the big question.
Do you have a question?
Do you have a particular like validated like questionnaire? Because I guess it's challenging. What I'd imagine in that, you know, let's say for example like shoulders, like objectively, this much range of motion, and then you know increasing. So like from a questionnaire perspective, do you have a particular battery that you use to monitor?
Depends on the condition. We have like a most broad one would be dizziness handicap inventory, but we have depending on it, we have vestibular migraine questionnaires, we have Vigada for the PPD or VVAS or situation vertigo questionnaire. We use like different questionnaires, depends on the condition or what's their trouble, like problem. Are they having that visual vertigo, or if we want to, usually dizziness handicap inventory is the one when we want to just overview is the best one, like the one that we would use, but really depends on the condition we might add in the other ones. Or functional gait assessment is really common one that I use for the dynamic balance. MCT SIB is for the like static balance. So yeah, but like those are the tests, but like a questionnaire point of view,
Yeah, cool. Thank you. Yeah, I've used the situational vertigo before.
But
yeah, I was just curious. Thank you.
Yeah, so yeah, that is like good when people are getting the dizziness in like busy environments.
Yeah, and the particular patient I'm thinking of was like a post-vaccine reaction, and it was very much in the car, changing direction. So yeah, so when I was looking through it, the questions seemed most appropriate in his circumstances. But no, that's good. I noted that down. Good.
Very good. You guys ask questions. I'm just going to ask the stupid questions because, you know, obviously this is not my area of expertise. So I guess I'm sort of trying to ask the questions from the floor that, you know, for people that might be listening later. I really liked your comment about how they describe vertigo, because of course we sort of lump it together. And I'm working on that when people describe pain. Can you just run me through again? There was 2 things you said. There was off-balance vision bouncing, but then you went on to say that the elderly don't even describe that sort of prelude of vertigo. They just say that fall. So can you just run through the words people use and why the elderly don't describe?
They would use, like when I see my clients, a lot of time they'll use really different words. It can be like off balance, dizzy, wobbly, like whatever, like, and then I want to really get into what it actually means. Like, is that spinning, or is just feeling a bit dizzy, off balance? When I mentioned the word bouncing, that's called oscillopsia. That comes when people have both-sided vestibular loss and they have trouble stabilizing the gaze when they walk. And then when they walk, they feel like the whole world goes like this. So, and then as I mentioned, when people like elderly, as for people in a younger age, when they get BPPV, the crystals, they will feel it as a spinning vertigo. Like they actually will feel the room, like every time when they lay in bed, their like room spins like up to 1 minute, and then they feel better. But elderly, like because as mentioned, just like decrease, like as we lose muscle mass as we get older, like they just don't sense it as much more anymore as a spinning. they still can. Some people still feel sensitive as a spinning, but sometimes it just presents as falling frequently. And then we want to do the BPPV testing to see is the BPPV there. But sometimes it's just like, I have clients coming in because like daughters saw that mom is starting to fall a lot, and then it's actually BPPV. Sometimes they might still feel like dizziness. They don't describe it like room spinning, they're more like dizziness. But yeah, it really depends on the person. As I mentioned, the same with the BPPV, like when I talk about crystals, like some people get so severe reaction, they like start to vomit, they like, don't like really sick. The other ones, like easy, I can go through the maneuver several times during the session, they're feeling fine. So it really depends on the person as well.
It's exhausting.
You're right. I like that.
It's so hard to
Keep
make
their
sense of
balance.
it. Yeah.
I like that brain fog and the fatigue from the just
Yeah.
concentrating on.
Really underestimated like how much that actually can give the, especially like when people trying to get back to vestibular neuritis, trying to get back to work, like the brain fog is really like underestimated.
And you just sort of mentioned post-operatively you said after a protracted period of bed rest.
Yeah.
So can you just run through what happens to those patients? So they're in bed for a week.
Yeah, again, like it doesn't happen with everyone. It's again more likely elderly who already have osteoporosis, osteopenia, and they are in that prolonged bed rest. It is something that can happen. Is the BPPV? So again, when the crystals go into the semicircular canals, that condition. It's more because they might be like more in fixed position for a really long time, and when they already have osteoporosis, osteopenia, and some other like health conditions, it's more like can happen, but it doesn't mean that it will happen with everyone.
What would quantify as like a prolonged period of time though? Do you like, would there
It
be
really
like a-
depends on the person. Yeah.
Really? Like a couple of days or
No, it's more.
more than
Yeah.
that? Yeah. Okay. Generally, what you would see is someone who had a couple
Someone
of
who has
weeks.
had like a longer, or the older elderly people who are staying more, being more sedentary and more like more bed bound as well. Yeah. But it's not really like common. It doesn't like happen with everyone.
Yeah, we just see in that scenario, we sometimes see their sodium levels drop at the same time. These very slim patients, and their sodium levels drop and they get dizzy, and then they fall and they break something else. So they get a secondary fracture because they had a hospital fall, right? So it's the hospital's fault that they had a fall. Do you understand? So the question is, is there an opportunity in there for a patient that we know is going to have bed rest for a week? Is there an opportunity there for them as part of their post-operative physio to not just be trying to move their arms and legs around? Is it something else that we could be thinking about, more holistic sort of care?
It depends on our operation, but as a physio, we always post-op, we try to get them up sitting, try to get them moving as quickly as we, depends on operation, but that's always like physios in a hospital
That's the
setting.
first thing we're doing. And they keep getting, they keep fainting. It's quite a big problem, and we understand that they're dehydrated, and sometimes it's they've got some urinary retention, so we understand we've got a trigger there. But are you saying that there could be something else we could be doing as far as when we go to sit them up? I mean, is there something positional we can be doing with their head as well?
No, again, like getting people up moving, and as I mentioned, this like happens, but it's not really common thing that it's like gonna happen with everyone. So it's just something that can happen when some elderly people are staying in a bed for a long time. But in a hospital,
before we sit them.
Well, the fainting is probably different from like
the hypertension. Fair enough. If their blood pressure drops, well, all bets are off. But I just wonder if
the reorienting.
These people sort of pounce on them and say, "All right, now you're getting up," and there's tubes of, it's a pretty stressful environment.
Yeah, it is a stressful environment for people. Yeah.
And they're very disoriented. They're very frightened that they've had a big operation, and they, presumably there's some anxiety associated with that. And then you're right, they struggle. You're right. They really struggle to say, "I'm feeling dizzy," because I say to them, "Why didn't you tell me? Why didn't you say something when you said could you tell me you're feeling lightheaded?" And I didn't realise that they may not be able to tell me that they're feeling lightheaded. They're just down they go. So are you saying it's so quick for them? They just can't appreciate it.
Like sometimes, as mentioned, it might feel more like they come upstanding and they feel off balance.
Sure. But they might not be able to articulate that in time.
They will say, I'm feeling off balance, but it's not like they will not tell that I feel my body spinning or dizziness. Yeah.
Oh, I guess what I'm saying is that you're saying that their sensory system is not processing it fast enough for them to be able to say, oh, I don't feel very well. They just fall down. I mean, obviously we're talking about a hypertensive scenario, but you're still saying even in a dizziness scenario, they can't articulate it.
It's more the fact that as we get older, like the vision gets worse. Same with the vestibular system, they don't interpret that in the brain as much as the dizzy. They're more like off balance feeling. Like
so it's like blurry.
Dull. It becomes more dull.
Yeah. They don't feel like
blurry vision.
They might feel more like off balance feeling instead of actually feeling like spinning or dizzy.
So it can affect like your proprioception as it progresses as well. Oh shit.
It's just it will affect like the people can just like fall more frequently, but without like actually like feeling like how to say that they have more frequent falls. But when you do the testing, we might say like, oh, that's this, like a BPPV there, and that's why the person has had these more frequent falls.
Yeah.
And then when we fix it, they feel better. And then
so you wouldn't know until you do the testing. So you're just getting people who present with falls.
Yeah, when frequent falls, dizziness, vertigo,
Yeah. So you just mentioned stroke there briefly. Are you seeing patients with just some mild sort of nystagmus that are actually having TIAs? Is that what you're thinking?
Some vestibular neuritis, because they present with such a severe vertigo and they get nystagmus as well. So we have like testing that we do to identify, is this looking more peripheral or it looks more central? Central is stroke. And then when it looks more peripheral, we're going to treat it as vestibular neuritis. But if we have central signs, we're going to send to PD.
How often do you do that?
I don't, because my diary is pretty booked out, so these people are acute like dizzy. Because my waiting time at the moment is for like 4 weeks, so they I will not see them because they just can't fit in my diary at the moment. So I started to do like some acute spots in my diary for them, but so far when I have had them, these are already people who have had like vestibular neuritis. They ended up in a hospital and they come and they have had like 4 days symptoms or something like that.
Yeah. Okay, so if you were able to, so you're a GP.
That's
someone with dizziness. So
that would be really important testing for them to do.
And so the patient could just come in with I just feel a bit dizzy, and that's all they're going to give us. Like they're not going to sort of, is that what you're saying? And that could be...
No, that's still, they would
you still see the nystagmus.
Yes, like when it's vestibular neuritis, they get nystagmus. Yeah. And then we do the testing to identify is it looking peripheral or central. And then again, we would question like how long it's been going on, is it triggered by something? Because if they come in and they say we're dizzy, it might be something else as well. And then we need to do the testing and questioning. So it's a lot of questions to get the correct information, and then a lot of like actually correct testing to make sure we get the correct diagnosis.
Oh no, that's
so balance exercises. So you had a picture of that guy standing on one leg with his leg in the air. You're doing a much simpler version of that for the older patient. So what are you doing for these patients? Are you
for balance?
Well,
It really depends. So it's really functional training. So what they want to get back to, like if they have problems with their static balance, like that means they're standing, and then for example, if in kitchen they're like trying to get the stuff from the cupboard, they have trouble with that. We will work on this, these movements, like shifting the body weight around, like adding the head turns in, because a lot of times their head movement will give them dizziness. So like adding some head movements in. If they have trouble with dynamic balance, like walking while they move the head, we will add more in those kind of things. And like really doing like narrow stance balance training, adding in some like dual task, really depends. Concussion, we will add in more cognitive load. So really depends what's their goal, what we want to get back to, what is impacted. So it's really really different, depends on a person. Yes, elderly, we're going to be more careful and making sure we really like supervise them and they do the balance exercises. And when we give something, to make sure they're really safe doing it.
Do you think the patients benefit from having you nearby as they try and sort of extend themselves into these more, what they feel is more scary sort of position? Is that what you're doing? You know, so that gentleman that you showed standing on one leg, he looked pretty concerned. He looked pretty frightened. So obviously he's had something that he's really, like that was obviously, he was quite uncomfortable. And so having you there to show him, do you feel that helps him sort of desensitize himself? Is that what he's doing to the new position, to getting...
With the balance?
Yeah. Are you desensitizing their brain to
When we do the balance training, what we want to do is actually improve the balance. So like helping like vestibular system, vision, proprioception, everything to work together again, and then do really functional tasks, like what the person actually needs to do in their daily life. Yeah, and then we
Getting all the things to
yeah,
talk to each
exactly, and then we just like add in the level of difficulty depending on the age and what they actually need to achieve. If it's athlete, we're gonna like push them. But if it's like elderly person, we will be more cautious. We want to know if it's like whatever is their goal, we're going to work towards that.
I think to come back to, I guess, what you sort of, some part of what you were asking us there was like, I think it's going to be contextual around like the individual's like appetite for risk. In that, like, because I guess when you're there, they feel like supported, and maybe then you can do like some more risk-taking exercises, as compared to often you might then, to a point, like scale back or scale down what they might do independently, depending on like their confidence and fear. Because if you're there and hands-on, or if you've got parallel bars, or whatever like environmental things you can put in place like in the clinic, then often you can either extend it in the clinic or scale it back for at home, depending on how they
respond to it. And then of course it's in the news, concussion, motor neuron disease. Do you think they're related? What's your opinion?
I also did mention that.
Not the motor neuron disease, it's more the damage through the brain to increasing incidents. That's like not motor neuron, but it's like just the changes in brain tissue because of the increased incidents.
This motor neuron disease, that should be a peripheral condition, right?
That's what I would have thought, because I've asked the same question.
You've been asked already? Really?
Yeah.
And go on?
No, I was just, when I got asked, I thought, well, as you say, motor neuron, peripheral,
it's peripheral,
concussion central, it doesn't make sense to me, like, physiologically.
That's why I haven't looked into research in that, so I can't say anything.
Well, what I was reading was they were saying the numbers are just so small, it's going to take us ages to work out if it is actually related to the game. Do you know what I mean? Like, is this just a random blip? So they have blips in cancer incidents or whatever. Is this just a blip, or is this actually a relationship? So I wondered if you had an opinion.
I haven't looked research with like motor neuron disease because this is so I haven't looked into research on that. We'll look it up to see is there anything. I'll
save that question for Sunday when I've got Eliza at the.
Eliza.
She passed that one off.
I'll let Eliza know.
Look up the research. Because this is really peripheral. It's still like
It's more what I'm looking for is not the research. It's your professional opinion. Can you see any sort of connection? I can't see any connection.
I wouldn't have thought so.
Oh, it's weird. Sorry, have you guys got more questions? Yeah, more research. So that's always the answer. More research.
More research is needed.
One more question.
So
I just want to know what would be your approach in terms of like assessment or management to those dementia population or those with cognitive impairments, because they can't answer describe their dizziness to you, and also they can't cooperate well for you to do the head impulse test or kind of stuff. So how would you?
So far, when I have had the dementia patients, because again, it's a lot of times how you approach to them as well, and then I have been able to do the testing, but again, it comes down to the fact how they will how supportive their people around them are, and actually will help to do the exercise because they will not do them. So bringing them more in the clinic to actually do the exercises. If it's going to be balance training, for example, or making sure they have a safe space at home, someone looking after them when they're taking for the walk, or making sure they get some exercise in. But so far, when I have had I have been able to do the full testing, or might need to do it over several sessions. Sometimes I do the major ones first, and then if I want to really check something else as well, I'm gonna space it out over sessions as well. But from physio point of view, as you work with the dementia patients, you really have to be mindful of different aspects there. So that's going to be just for me as vestibular physio as well. Same, I will take it into consideration, what they can do in a session, and then how supportive their home environment is how much support they get from the close people to help to go for a walk, to go like to get them more out of bed, because usually they just end up being in bed if they if they really don't have that initiative to go just get up. But yeah, with working with dementia, it's same as like it's just with every other condition, but a person with dementia.
Well, it's just you've got no retention to teach them something.
Yeah, it's interesting because like with the work we do in like the nursing home, in the memory support unit, they'll have frequent fallers, but so it's like balancing to say.
Again, there might be like with them, if there might be some PPPV underlying, and that's going to be easy. Like I have had dementia clients with PPPV, and that's the maneuver that we would do, and then that will help them. So again, what's the actual reason why they're falling, or we'll do the testing to find it out, and then we will do the treatment accordingly. And if it's PPPV, we will do the maneuver. It depends on what canal it is.
Can't use a questionnaire though.
No, I can't.
Questionnaires just gone out the window. So what are you going to do if you can't take a history of a symptom?
A lot of times with them, what I have is someone daughter is coming with them and gives me a history as well.
Correct.
Yeah.
That would be hard.
Yeah, because they're separated from family. They have got a consistent person.
And not someone who's with you might be
They have
two care workers to what is it, 11 patients, 2 to 1. So you don't have that 1-to-1.
I guess it's gonna be same if it's like MSK conditions. They won't be able to tell you.
No,
if they have
that was the parallel.
It's just a little bit special, like another test that you need to know how to do, and subjective, I guess, can be pushed away a little bit if they can't answer, and then you can go with the objective.
What kind of objective would you recommend for them?
Well,
Because they can't cooperate with the instruction well. They can't follow the instruction. For example, for the head impulse test, you have them to fixate onto something, but they can't. So that's why it's hard to get a true result for that.
I guess you have to kind of weave through to see what works or not.
Yeah.
That would be the same as can you raise your hand?
So
would they be able to follow it? So.
Just what you can. And when they come to the head impulse, we have another test, different tests that we can test if you're considering unilateral vestibular hyperfunction. We have mastoid vibration test, we have head shaking test, and then we might do the DVA with them, and that can be with letters or dynamic visual acuity, and might be with letters or pictures. What I have used with my dementia clients, actually using the keyed version for pictures for them, because that's what they can recognize if they can't remember the letters anymore.
It's a kid's version.
The kids version. Oh, okay. That way.
Well, just version of with pictures instead of letters.
Yeah. Well, it's a multi.
It's like a multi. It's for easy to use with kids, but also for So there was be more ways to identify. Not only one test will we will do different tests to put everything together and to identify what's going on.
Do you find a difference between chronic and acute patients in terms of how they can articulate what's going on? Because I imagine with some chronic, like you said, if it's when they're acute, they're a bit dizzy in the car or something, it's more normalized for them. Whereas acute, you have a certain, I guess, functionality up until a point, so it's more noticeable. Do you have any issues, I guess, with the question side of things for acute or chronic patients?
Do you mean do I question different things, or
just the patient's ability to articulate what, whether it's a dizziness thing or the
it's usually with the acute one, because they will be Tuesday I was up and I was dizzy, but the chronic ones
with the exacerbation.
Chronic ones when I because for me I want to know how many spells they have had. Is that the ongoing, or they actually get those episodes? And sometimes with chronic it can be a bit difficult when I'm asking what do you remember the first episode, and they're that was 20 years ago. Can't remember, because again, for me, I would ask how long that episode was going to know, again, differentiate in my head, what it can be, and then usually it's gonna become a bit more difficult, because if they were in a like they might remember it, but a lot of times they will be like, oh, that was 20 years ago. I actually can't remember exactly how long it lasted. Or like sometimes they remember how many episodes between, but yeah, it's just like just memory factor comes in as well. So acute, it's gonna be easier because it was just now, and then they will be like, oh yeah, it just started, and it's really easy to like explain what's going on with the chronic. Really, it depends on the person as well. Some people are really good at telling like, I was really dizzy, went to the hospital, was there in 2 days, and
because I imagine it would be quite challenging for a patient to articulate because dizziness is such a broad term. So it would be quite a challenging process for you to ask not only the specific questions, but to make sure that they comprehend exactly what you mean as well. So like, it would be quite challenging to get through that process before the visual testing.
When I ask them questions, it sometimes takes me 20 minutes there to get all the background information. And just because I ask about hearing, I ask about like balance, medical history, like all the episodes that might have, or with like chronic condition, triggers, like there's so many things that I ask.
Like, and they're probably like,
because but that will narrow down what test I will do. Otherwise there's so many different tests that I can end up doing, but that will help me to actually just do really specific testing.
Have you been in a situation where you couldn't get a good enough answer verbally that you have to sort of go through the testing process?
I always go through the testing process anyways.
I mean, so more broadly instead of like being more targeted.
When I'm having the subjective, I'm gonna get the subjective information, then I'm always putting myself writing down like the differential diagnosis, that what it sounds like it can be, and then I'm just gonna go, for example, if I feel there, I'm gonna start to like test when I have PPPV. I'm just gonna start to test, like do the testing to rule them in or rule them out to see which one it is. And sometimes it might be, like, as mentioned, they're more complex and they just actually have several conditions that is happening with them. Or if they're really symptomatic, it might be like spaced out a bit more over the sessions to make sure like that I get the information, but I'm not making them really sick.
Very multi-layered.
And I think that's why it's been so complex over such a long time, is that with layer upon layer upon layer.
It's really interesting area. I really love it. It's so exciting.
Great question. That made your question. You win this year's question. You smashed us with that one. All right. Well, thank you very much. That was really wonderful, and I appreciate. Thank you very much. Appreciate your time tonight, coming in and teaching us all about that. I certainly. The thing that probably I want to tie together is that getting patients we're trying to get patients to say things in certain ways so that we can hear it. But I think what I've learned, when we're talking about pain, they don't always say pain the way I'm expecting them to say pain. And so just vertigo, I think, is a whole other layer of trying to get the patient to say what I want them to say. That's not quite what we're supposed to be doing. We need to be listening to the words that they're using and trying to interpret what they experience. And particularly if it's something that's chronic, that they've had all their whole life, they don't even think that it's not normal, so therefore how can they describe that experience? So thank you. Very good. Thank you.